Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of interviewing on this podcast one of our former fellows, Dr. Floriane Jochum, who is at the Institut Curie and also at University Hospital of Strasbourg. Reason for this podcast is a recent article published in the great journal, the American Journal of Obstetrics and Gynecology, titled Survival Outcomes of Primary versus Interval Cytoreductive Surgery for International Federation of Gynecology and Obstetrics Stage IV Ovarian Cancer and Nationwide Population-Based Target Trial Emulation. Floriane, such a pleasure to having you on the podcast. Thank you so much for accepting our invitations, and really congratulations on this impressive publication.
Thank you so much, Pedro, for inviting me. And yeah, it's been quite a while since we last spoke, but it feels like yesterday when I was an editorial fellow at IJGC. And so it's truly an honor to participate in this podcast and to discuss about this publication.
Yes, and I do have to say I do want to congratulate you because you have been really very, very productive academically and successful in your academic and professional career, even at this very early point in your career. So congratulations.
Thank you so much.
So Floriane, let's start talking about some of the details on the study. So primary versus interval cytoreductive surgery for stage 4 ovarian cancer. So I wanted to start by first defining stage 4A and 4B ovarian cancer, and then discussing as to why you thought this was an important question to address in our field of gynecologic oncology.
Yes, of course. So let me start by defining stage 4A and stage 4B ovarian cancer. So stage 4A is characterized by malignant pleural effusion with not other distant metastasis, while stage 4B involves distant metastasis beyond the peritoneal cavity, including lymph nodes, liver, lungs, or brain metastasis. The questions that we ask in this study and that we wanted to investigate is: what is the optimal surgical management, primary versus interval cytoreductive surgery, for advanced ovarian cancer, especially with extraperitoneal metastasis? The Curie and ERTC trials show similar survivals between the two approaches for advanced stages, but there have been some criticized for the low median survival and also for the complete resection rates, which was quite low. And only few studies, observational studies, was focuses on the FIGO stage 4A and 4B because it's the lack of patients. It's still rare, and we still don't fully understand how extraperitoneal metastasis location affects survival with the different surgical strategies. So that's what we wanted to clarify in the study. Yeah.
Excellent. So thank you for introducing that topic as well. Now, can you share with us what is the French health insurance system database and what kind of information does it capture? And also, what kind of information is not available?
Yeah, so this database is for us a gold mine because it has the data of approximately 99% of the French population. So it's around 60 million of patients. Yeah, it contains data, demographic data, so birth dates, sex, residence informations, vital status, death cause, death date, and also everything about the hospital discharge report, so the diagnostic code, which medical or surgical procedures they had, or if they had expensive treatments, and also everything about outpatient care, so which medications they get at the pharmacy, which laboratory tests they have, and also other medical procedures they have. we don't, I mean, in the hospital care, we don't have all the treatments they get. We only have the costly innovative drugs. So we have limited data about which chemotherapy they have, but we can infer a lot with algorithm, with the diagnostic code, with when they have the chemotherapy station. So with this, we can have, for example, the stage figure 4, we didn't have it in the database, but we infer this with all the diagnostic codes, the surgical procedures they have, the chemotherapy pattern, and so we can complete all the information we don't have with this database.
Wow, what a great resource you have in that. So I wanted to then now get into some of the methods of the study. What is the primary aim of the study, and what were your inclusion and exclusion criteria?
So our primary aim was to compare progression-free and overall survival between patients treated with primary versus interval cytoreductive surgery for patients with ovarian cancer with FIGO stage 4 ovarian cancer. And we included only women, aged women, so older than 18, between 2013 and 2022. Under 75 years old and with fewer than 2 comorbidities and no indicator of poor health status, and who underwent surgery, primary or interval, within 9 months of diagnostic. With exclude patients, we didn't get the standard pattern of chemotherapy, and also those with mobility limitation or sign of comorbidities, and of course patients who had previous ovarian cancer. The main goal of this was to select patients who could realistically be candidates for either surgical approach. So these patients should be able to have primary or interval debulking surgery. That's why we restrict the population to patients who are good at ovarian cancer diagnostics.
Great. So now, for a component that you well remember, when the fellows ask the speaker a question. So we're actually going to get into some of the questions by the fellows on the methodology, because they did have some questions about the methodology before we get to the results. This question comes from Stephanie Gill at the University of Toronto. And she says, your study used target trial emulation with inverse probability of censoring, waiting to address confounding and selection bias. Can you elaborate on the specific challenges of applying this methodology to real-world data? And how confident are you that it accounts for all potential biases, such as immortal time bias, which could be a particular risk for BRCA-mutated patients or those receiving immunotherapy?
So, yes, of course. Think like this way. You want to conduct a randomized trial. When you do that, you are extremely clear about the question, who you are studying and how you will analyze the results. And that's why we trust these trials. With observational studies like ours, we don't have randomization, but we can still just be as precise about the questions we want to analyze and the method we want to use. And that's actually what target trial emulation does. It forces us to specify exactly what randomized trial we would have done if we could, and then follow those same rules with our real-world data. So this approach avoids several common bias, like selection bias and immortal time bias. So, for example, we define who is eligible for our study at the exact time they would have been assigned to the treatment strategy, not earlier and not after, which prevent bias like immortal time bias. But this framework does not avoid all bias. We still face limitation like measurement error and unmeasured confounding in our data. The framework doesn't avoid this. but it makes our assumptions and more clear and more transparent. So perhaps more importantly, it ensures we are asking a precise questions, because after all, we cannot find the right answer if we are not clear about what exactly we want to study.
Yeah, very interesting, unique approach. And as a follow-up to that, Manuel Montesinos Albert from Valencia, he asked, how does this study's target trial emulation approach improve reliability of conclusions compared to traditional observational studies?
Yes, well, like I explained before, it's for us to be like crystal clear about what we are studying. We have to define exactly what randomized trial we would run if we could do that. It creates strict rules about who is included in the study and applies these rules consistently to everyone. It allows, it also makes us clear upfront exactly what outcome we will measure and how we will analyze them, like in a randomized trial. And it keeps us honest about our assumptions and limitations, making them more visible to others who want to interpret our findings. And also, as I explained before, it solves the tricky problem of when to start tracking a patient. And we follow them from the moment of treatment decision and not before and not after, eliminating a very common bias in observational study, where sometimes we think like some treatments have immortal patients because it was not well accounted for. So altogether, this advantage makes our result more clear and closer to what we would expect from a randomized trial, even so we are using real-world data.
Great. Floriane, one additional question on the methodology. This one comes from Julia Gellison in University of Wisconsin in Madison. She says, can you explain the rationale behind creating clones of each patient's records and including them into each arm of the trial, then using artificial censoring to later remove patients whose course did not fit with the treatment arm? How does this ensure comparable baseline characteristics in the arms if the clones are later removed?
Yes, so I will try to explain all the concept of cloning censoring weighting method. So imagine you want to compare two treatments, primary surgery versus interval surgery. But we are worried that the patients who got each treatment were different to start with, make it an unfair comparison. So what do? We create a clone of each patient and we put one version in each treatment group. This way, both groups at the beginning have exactly the same patient, so they are perfectly balanced. Of course, in reality, each patient received one treatment, so we need to censor the patient from the group that doesn't match what they actually received. So for the patient who actually received primary surgery, we remove them when they got the first chemotherapy because it doesn't match anymore. But when we do that, the clever part is that we do a mathematically adjustment for it with weight. So we are giving extra statistical weights to similar patients who remain. And so it's like this remaining patient now represents herself plus the patient we just removed. So at the end, we have a comparison that mimics what would have happened in a randomized trial when treatment assignment is random and groups are balanced. Even so, we are using real-world data where treatments were not randomly assigned.
Great. Fantastic. Now let's get on to the results. 2,772 patients with either stage 4A or 4B. What were the highlights of your study?
So what did you find? We showed that primary surgery showed clear survival benefits compared to interval surgery for all the patients stage 4 ovarian cancer. For progression-free survival, we find that patients who had primary surgery lived about 5 months longer without their cancer progressing. And the median time to progression was about 20 months with primary surgery versus about 16 months with interval surgery. For overall surgery, we find the same. Primary surgery added about 4 months to patients' life. And when we look at specific patient group, we find even stronger benefits for patients with stage 4A disease. But even patients with stage 4B disease still show meaningful improvement with primary surgery. And when we look at the location of metastasis, we found that patients with pleural metastasis, metastasis above the diaphragm or metastasis to lymph nodes outside the abdomen also did have better survival with primary surgery. However, and this is important, we didn't find that for patients with brain metastasis or uncommon metastasis to have a significant improvement of survival with primary surgery. So this suggests that, yes, primary surgery is only beneficial for a location where actually is resectable and the surgeon has the capacity to remove it. Yeah.
Great. So now, of course, obviously, lots of questions about these results. First one, Manuel Montesinos, back from Valencia, he asks, how did variations in the number of neoadjuvant chemotherapy cycles, fewer than 3 or more than 6, affect progression-free and overall survival in patients undergoing interval cytoreductive surgery? And how is this accounted for in the study's analysis?
Yeah, so that's a great question about the chemotherapy cycle. So yes, of course, we find that the number of neoadjuvant chemotherapy cycle really does influence outcomes in patients getting interval surgery. In our main analysis, we only focuses on the patient who got the standard 3 to 6 cycles of neoadjuvant chemotherapy. Just by interest, we look at who was the surgery, the patient who had less than 3 and more than 6. And we find that about 12% of the patients in the interval surgery group got fewer than 3 cycles, and they generally had poor outcome. This likely points to either the disease progressing rapidly during treatment or there was not tolerating well the chemotherapy. On the other side, we found that about 8% received more than 6 cycles, and these patients show mixed results. Some benefit from the extended treatment, while others probably got those extra cycles because they was not responding well or were not ready for the surgery. So in our study, to handle this variation, we censor patients when they deviate from the standard protocol. So if they receive surgery before 3 cycles of neoadjuvant chemotherapy or after, we censor them and then we apply the same technique with the weighting method. So we didn't keep the patients that were fewer or more than 6.
Yeah. Okay. And this question from Julie Gellison is, do you have data on how many patients were excluded for being older than 75 or multiple comorbidities? And if so, how applicable do you think this data is to the overall population of stage 4 ovarian cancer patients? Do you have any data on the extent of extra abdominal debulking performed for stage 4B? So Julie got a few questions in that one question.
Yeah, so we excluded about 800 patients older than 75 and around 600 patients with multiple comorbidities. So for the generality of the results, our results only apply to the population we study. So it's only works for the populations that are in good health at the beginning, not older than 75 and with less than 2 comorbidities. And we needed to do that because we needed to be sure that at the beginning, each patient could have each strategy. Otherwise, the emulated trial is not feasible. Regarding extra-abdominal debulking for stage 4B patient, we didn't have exactly the exact data on how extensive the debulking was, but we had proxy measure like metastasis code and surgery types that help us to identify patients who had more extensive procedure, but we could not precisely measure if debulking was complete or not. So, of course, this lack of detailed information on residual disease is a limitation of the study. However, we minimize this bias as much as possible by adjusting for other factors such as the extent of surgery, the metastasis location, intra and extra abdominal, and also the expertise and the center volume.
Great. Now, Thomas Bartel from the Medical University of Vienna, he's asking, couldn't changes in clinical practice related to biomarker-driven patient selection over time have confounded patient selection, even if the relative proportion of patients referred to primary versus interval remain stable?
Yes, of course. Clinical practice changed from 2014 to 2022, and especially regarding biomarker-driven patient selection. So yes, this could be a source of confounding despite our methods. And by 2022, BRCA testing had become much more standardized compared to 2014, potentially influencing treatment decisions. So, for example, a BRCA positive patient with high tumor burden might have been more likely to get neoadjuvant chemotherapy based on emerging evidence about chemosensitivity. Our analysis shows stable proportion of patients getting primary versus interval surgery over time. So we try to account for this by adjusting by the year of diagnosing in our analysis, but of course I guess some confoundings likely remains, and we will need to have some other data about this to confirm our results.
Yeah. Now, on the topic of perioperative morbidity, mortality. Stephanie Gill from the University of Toronto, she's asking, did your data set allow for an analysis of 30-day postoperative mortality between the two surgical approaches? And I also presume she would also want to know about morbidity. And if so, what did you find? And if not, what were the limitations in assessing this outcome?
So yes, in our database, you can analyze the complication and the 30-day morbidity or the 30-day mortality between the two surgical approaches. For severe complication requiring a new intervention, so clavien grade 3, we had 16% of complication at 30 days for primary debulking, versus 13 for interval surgery, so it was a significance. And at 90 days, we find also a significant difference between the two strategies with higher rate for primary surgery. However, we didn't find a significant difference for mortality rate or for life-threatening complication. The 30-day mortality rates were similar, about 1.1% for primary versus 0.9% for interval surgery. And interestingly, we find complication related to chemotherapy more frequently in the interval surgery, like neutropenic infection, neuropathy, thrombotic events, and that were less frequent in primary. It was 38% in interval surgery versus 24% in primary surgery.
Yeah, indeed, an interesting finding. Christian Braun from Lucerne Hospital, he's asking, in your assessment, what were the main factors influencing the decision to perform primary debulking surgery despite the presence of extra abdominal metastases? Could this introduce a selection bias or a confounding in the study results?
We found that several key factors influence decisions to perform primary debulking surgery despite extra-abdominal metastasis. First, it was the patient characteristic, so younger age, fewer comorbidities was strongly associated with primary surgery selection. Second, we have a center volume and expertise. High volume center performing more than 20 cases annually were more likely to do primary debulking surgery, particularly for these cases with extraperitoneal disease. And third, we have also the hospital academic status, with academic center show a slightly higher tendency to attempt primary debulking in complex cases, possibly due to the greater multidisciplinary resource and specialized surgical expertise. So we adjusted for all these variables in our model, but I can't say that there is for sure no unmother co-founder remaining. This limitation must, of course, be considered when interpreting the result, and so, but we find consistency of the result across the different subgroups and sensitivity analysis. So I think it's there might be residual bias, but all the analysis we made was still consistent. Yeah.
Excellent. So now Thomas Bartle from Vienna is asking, I noticed that only a third of patients received adjuvant bevacizumab. What do you believe could explain the relatively low use of adjuvant bevacizumab in FIGO stage 4 patients?
Yeah, so actually, I don't know what is the number in the US, but in Europe, is a normal number. Actually, there is another study that was evaluating the use of bevacizumab in high-risk ovarian cancer patients, and they find 38% of the patients, so it was quite the same. In France, bevacizumab, I think, was approved in 2011, and the patient selection has become more and more defined over the years. We prescribe it, yes, for stage 4, for unoperable patients, or for suboptimal debulking. But obviously, we don't do it for everyone. I'm not sure exactly for the why. I know that some surgeons don't want to prescribe if there was an extensive bowel surgery due to the concerns about wound healing and anastomotic complications. And there is also the emergence of PARP inhibitors that you need to take into account, and all about the comorbidities, age, and all the side effects about the bevacizumab.
Yeah. Now, Floriane, I wanted to ask you, what do you see as the main limitations of your study?
The main limitation of the study is, I think it's what we talked about before, it's we can't exclude residual confounding, even if we trying to find proxy for all the main factors. We cannot exactly have the residual tumor volume at the end or the exact pathology findings. This could affect the results. And we also lack molecular data on BRCA mutation and HRD status, which increasingly guide treatments decision today.
Yeah. So now, Floriane, as a last question, as you remember from your fellowship, we always like to ask the authors of these manuscripts, how does this impact our practice? And Matteo Marchetti is asking, your findings really challenge the conventional preference for interval surgery in patients with stage 4 ovarian cancer, especially those with extraperitoneal metastases. So based on your results, how do you envision these findings influencing future clinical guidelines in surgical decision-making? Should patients with supradiaphragmatic or extra-abdominal lymph node metastases be routinely considered now for primary surgery when feasible, potentially within a multidisciplinary surgical team?
Yeah, so I think the conclusion of this study is not that the new standard of care for FIGO stage 4 is primary surgery. is not what we want to say. What we want to say and what we see in many centers is that when we present the cases of a patient with FIGO stage 4 ovarian cancer, you say, okay, stop, it's FIGO stage 4, so it's interval surgery, and they will go to neoadjuvant chemotherapy. What we want to show and say is that it needs a discussion, an individual discussion for each patient with the oncologist, with the surgeon, and a discussion about, okay, but look, here the phagocy is okay, and we only have metastasis, in inguinal metastasis that we can easily remove. So yeah, I think we can go to the surgery. This is the conclusion of the study. Is now we need to discuss every time we have a stage 4, is it possible or is it not possible? And we can't say anymore, okay, FIGO stage 4, it's neoadjuvant chemotherapy without a discussion.
Excellent. So, Floriane, it's been such a pleasure speaking with you about this study. Really very interesting findings, and I'm really glad we had an opportunity to go through some of the details of the study. I want to congratulate you, of course, again, and the co-authors of this paper for a really fantastic work. And again, thank you for accepting our invitation to doing the podcast. And we really look forward to more work from you. Really interesting work. Thank you.
Thank you very much. Bye.